Fishbowl. So I see a lot of hands popping up, and we're about to go into the fishbowl time if you guys have more questions with all the moderators up. So the question we have that will go, I think, transfer over to the fishbowl is from the patient panel to the patient. Yeah. What do you need and what do patients need to feel more involved in the policymaking process? So that can lead us off for the next session. All right. Thank you guys very much.
All right. Big round of applause. Thank you. Okay, I'm going to ask you to do two things. First, stand up and stretch. We are at the home stretch. Stand up and stretch. All right. Now, as you stretch, and if you want to, we're not really doing a break right now because we're going to go straight into the fishbowl. And now, as you stretch, okay, now everyone can come sit back down if you want to. Second thing I am going to ask, right now, I want to hear from everyone on what you all are thinking. How has this gone? What are some thoughts for the day from your perspectives? Dorothy, I'm going to call you out. Dorothy. Does everyone know Dorothy Teeter? So Dorothy Teeter is our part of our Innovation Council here at Cambia Grove. Dorothy, thoughts for the day?
Okay, 5 quick thoughts. And Maura gave me a tiny little warning, so I actually might be more coherent than some of the rest of you. So the desire and the opportunity to improve is as strong and powerful as it ever has been in the healthcare system. 2, artificial intelligence, tech, and analytics are powerful, powerful levers for problem solving, care improvement, and simplification of processes. And don't ever forget that. Just the comment about find the problem before you find the solution is really important. Third thing is complexity is still our constant companion. But there are spaces, as Bob was just saying, for collaboration, like in opioids, behavioral health, where we don't have to have complexity be the barrier. Fourth, money and policy are powerful incentivizing structures. Don't ever forget it. They create the environment within which we're all operating and need to be influenced. And last but not least, this is my favorite because I'm a culture kind of person, without trust, you can't do anything. So that is the key vital element for care improvement and any other kind of changes we want to make to the system.
That was awesome. All right. Thank you, Dorothy. That was awesome. Any other thoughts around what we've heard thus far? Steve, what are you thinking? Oh, you have a mint in your mouth. All right. I'll give you another second. Other thoughts here from the conference itself. And if you have been part of one of the 5 points panels, please make your way up to the stage to start having our fishbowl conversation. Some of the things that I've heard are centered around some of the infrastructure, incentives, and culture that are needed in order to make change. Change is hard, is what I've heard. How do we approach these problems kind of in a system level, but also with patients in mind, always in mind, at the center? Policy is tough. I haven't heard of enough awkward yet, and we'll get into awkward at this next portion. And so I'll give you a little flavor of what we're going to be doing this next portion. Okay, everyone can sit down now unless you want to keep standing, but that's up to you. But everyone sit down now, and we are going to do this fishbowl. Yep, John, come on up. We're going to be doing this fishbowl for about an hour. And the beauty of this discussion is that we have been collecting all of your questions on the poll everywhere, and we have them all now pulled together in these 2 pages. I want to make this as interactive as possible. And so as we look to everyone who we've heard from the 5 points of healthcare, we are going to start the question from the policymaker to the patient. So, is everyone ready? Oh, let me give you kind of the structure. So, fishbowl now, we'll take we'll break at the end of the day. We will have beverages, food, wine, soda, etc. for everyone to network as much as you want tonight. And then tomorrow we are going to get started into what we've heard today. How do we create action for change, and how do we do so in a community-based level, working with everyone through a couple of breakout sessions. So that is going to be the point in which we all go in and say, here's how we're getting things done. Okay, are we ready? Are we ready? Perfect. Okay, I'm looking at our 3 patient panel representatives, and your question from the policymaker is, what do you need to feel more involved in the policy-making process?
Honestly, I don't care about the policy-making process. I'm serious, I don't, right? Like, what I care about is, huh? Yes. I had an answer, but, policy, it doesn't matter to me, right? What matters to me is that I get better, I feel better, and I get what I need. So I'm counting on other people to go do the policy. So I don't need to really be involved.
And I would say at a higher level, like knowing my representatives, number one, like the basics of civic engagement is what I need. And especially within healthcare, if I am freaking out about, I've just switched healthcare, I was paying $0 for diabetes care, and now I pay $600 for every sensor replacement and $90 a pop for every insulin vial. I'm like, oh, and who's my senator and Congress people? ... It's just, and I don't mean to say like, civic engagement is second. It's not, but I think the basic awareness and encouraging, this is like aside from healthcare, I think generally our public, especially millennials, need better knowledge of that and active engagement there. And so I would just ask myself to do my homework of how, like, why, and know a so what, like what comes from engaging with policymakers, and what do we do together, or is it more like a just good to know sort of thing? Because I think experientially, I would doubt that we could point to policy. It's more so existed in an ether that we then experience through care or prescriptions, et cetera.
I think in my experience, patients have to engage in policy because it's about us, for us, and without us, that's a problem. However, I agree with Bert in that I'm all about action, like getting stuff done, and so the policy stuff is inherently very frustrating. So I applaud all of you who are engaged in it because it really takes perseverance. But what I think most patients would need to be involved is a very clear, here is what your voice can contribute to, and here's, in the end, what we can actually be hoping to pull out on the back end, if that's possible. From policy perspective, that's difficult.
That's great. All right, Fishbowl, you guys can, I will lead, but if you guys want to take a mic and go for it, go for it. Bob.
Not working? Oh, there
Yeah,
it
it's
is.
working.
Thank you. Ask a question. How, since the coverage you get, having to do with your insulin or even the basic benefits if there's a behavioral health problem, which is a parity issue, which was that was actually a public policy decision. I can understand it's hard, it's frustrating, it takes a long time. You do have patients, and people hate you to begin with, and after years they say, well, that was okay policy. But even if you're talking about, let's say your employers or whoever you're getting your health care from, we have a system where we have probably the worst outcomes in the developed world. In fact, we do have the worst outcomes in the developed world. We also have the highest prices by a twofold. If I were a consumer paying twice as much for a lousy used car, I would be mad. Why are public not mad and doing something?
I think people are mad, and it's unclear what to do.
And as you said, right, like I think people hate us, or collective us, right? And I think, when you look, so this is not a representative sample of most people with chronic illness in the United States, right? So you have parents who have kids at home have to keep down a full-time job, maybe 2 full-time jobs, have to fight with the insurance company every day, have to hope they get the care they need. The last thing they're thinking of is, oh, cool, how do I get involved in policy? Like, it's just not, and that's what I meant before, right? Like, in the world of priority, and I understand healthcare and I understand policy, but in the world of priorities, like me getting involved in policy is so far down that list, because I just, I think as she said, unless you can prove to me that me getting involved is going to yield something quick that's actually going to change the course of my life or somebody else's life, like, it's just a luxury, honestly.
I would add that I could get angry about my car and replace it. I would go on Craigslist. I would go on all these sites. I could go wherever I wanted. I can ask some friends, and it wouldn't matter where I would get it from. It would sort of be like, name my price, try and find that, make sacrifices I want, but it's legal. I legally buy it. Great. And here it's like, sometimes the process and paying for, like, I have to go, so Dexcom is my sensor and I go through EdgePark to buy it, and EdgePark delivers it, but to change anything I need to contact Dexcom, which again, such a privilege to have access to these, but the frustration is real. And then it's like Comcast, like, managing my diabetes is like just as hard as Comcast, and Comcast is really fucking hard, and you just like can't get through on the phone. And so if you systematically design something to be so obtuse that you can't break through, I think then you are left being angry without a belief that you can really affect change. And you don't see too many examples. Like, one, our world is media saturated, and two, there aren't too many examples that are clearly told through everyday language.
So I would say that my experience working in policy is that the patients' voices are the most important to legislators, period. Because the people who are paid to lobby for the organizations, I think we talked about this earlier, right, where the money is, they see those faces every day. They see those folks, they know that their interest is to further the interest of that company. But when they see the faces of people who have chronic illness, who need the system to change, flood the testimony, that matters. And I would say that the reason that we have the ACA is because people got mad. Now, it took a long time to get there, and it, my opinion, wasn't far enough, but we got systemic change because of it. We also, last legislative session, we passed Cascade Care, which was our attempt to answer the call for a public option, and we'll see how well that works. But that was because of the advocacy of patients. That was because of the people who, are boots on the ground, who are saying, hey, look, people are dying, we need answers now, and we need to make the system better. So I would encourage you, and maybe there's like a database we can create that is like easily accessible to patients to say, hey, these are the bills that are coming down the pike, how can we get your voice to the table?
But I think I think that is great, and that would work if there was a clear path, a clear roadway to participate. And let's face it, organizations like WASHA and Society for Participatory Medicine, that's not being funded by large organizations and payers and people who are involved in policy. And if we were to be able to have money to have grassroots and to demonstrate that to patients, maybe more people would know about these opportunities.
Let's talk offline, because that's exactly why we created Alliance for a Healthy Washington.
That's awesome.
Is for organizations that don't have the bandwidth so that we can be the voice in Olympia.
All right, I'm going to throw one more question, or another question out. And this question is so I have a background in policy. I worked with a .gov by my name for a good 10 years. And so there's a lot that we can do outside of policy as well. A lot of people look to policy to fix problems, but I would say that during my time, 70 to 80% of the problems that came through my door were things that didn't necessarily need policy to fix them. And so this question is, what is one thing from each of the 5 points that you would like the others to know, or a practical problem they could help you solve? Practical problem that someone around the table could help you solve. Don't jump at a mic all at once. All right, Doug. That one takes a second.
Yeah, I'll throw in a practical problem. We have an ER problem in Washington. Our ER rates, emergency room rates, haven't gone down for years. And interventions that we try to put in place, don't seem to happen. If you call 911, you're going to the ER. There's just nothing in between. It's a big problem, and particularly for our Medicaid population. A lot of the Medicaid population, or there's a piece of it that really uses the ER as their primary care. And we have patients literally that will go there 50, 60, 80 times a year. And we do intervene with them. We go out, we meet with them, and we try to do something different. But we need something in between. And it's been very hard to get the system together to do something about that.
Have you had much contact with the fire people? Because the law has
there's
changed,
pockets.
and there are places.
Yeah,
where
the
they're
law
doing
has changed, and there's pockets. You're right. In Snohomish, they're doing it.
and South King County.
Yep, South
Kid
King
Cass
County.
is talking about it.
Yeah, it just
What they're doing is the law has been changed, so they don't have to triage them directly to an emergency room, but they can actually do an assessment and triage them to the service they need. And so 85% of runs in 911 are non-fire. And so they are now, these pockets are actually developing. Actually, Puget Sound Fire hired a nurse practitioner, and they're doing, they're developing runs so that if they know the person's not a fire, they'll send out a social service group of 2 people, usually a nurse and somebody else. They'll then assess and triage the person to the place of appropriate. And it's really a huge savings. But they have, now the big challenge is where are they going to send them? Because we're short on behavioral health, we're short on drug treatment acutely and things like that. But
no, I think that's great. It just
that
needs
the
to
right
happen.
thing?
Needs to happen. That's exactly the right thing. Needs to happen faster, though.
okay.
All right, so ER, and we just solved it. Fantastic.
So
Done.
Hey, Mark, can I
Right? Check.
So can I ask just a question, like a follow-on?
Yeah.
So I'm curious, like, how much people look to other states, other cities to solve problems. Like, I know in Austin, I know that the police department there is completely trained on mental health, right? So that they know how to triage mental health emergencies on the scene, as opposed to putting somebody through the system and then figuring it out. Like, what's the process for people to learn from other municipalities, other governments, other states?
I could say from the United perspective, we have Medicaid in 26 states. So we look at innovations all over the country. I'm sure Melina does too. But we look at innovations, things that are working. We advocate for legislation that helps us. That was one of those things, which is, we needed legislation that allowed us to do something different than just taking everyone to the ER. So there are all kinds of innovations that are being tried all over the country, and we do take the things that we see working and try to pass them around to all the rest of our business.
So I would say that to that question, I'm on the Seattle Police Department Crisis Intervention Committee, and they're, of course, under a consent decree. And up until 1/1/20, we had one social worker for the entire city with the criminal justice system to go out on crisis calls. But through additional funding, we now have one clinical social worker for each precinct in the city of Seattle. So we're behind that whole process. So it's all about, what Dorothy said, it's all about funding, right? So that finally got funded. But back to your question, I would say from a purchaser's perspective, that was really profound to hear is this whole issue about integration of data, both on the HR, benefits, payroll, kind of all that administrative stuff, which may not sound very sexy to innovators, but it's really important, and it's very difficult to achieve. And on the other side, and from a benefits perspective that I see struggles, which I mentioned when I talked, is lack of real-time or close to real-time information sharing and coordination between the 14, 28, 58, however many vendors an employer has. Not, obviously the larger ones have more. That's a real challenge of having real good data integration so that the right person can make the right intervention at the right time with the right member. So we avoid redundancy, and we also don't leave someone alone that actually needs support or some kind of intervention.
So that sounds like one thing from each of the 5 points is this idea of data, of sharing data. Yeah? And then doing something with it.
And that's the key, right? So interoperability is the hot topic right now,
Yep.
but all you hear about is the technological side of interoperability. You don't hear about what person's getting trained to read the data from 60 different sources and come up with action plans based on that data. It's amazing, right? Like everybody talks about, cool, we're gonna have the systems to do it, and it's like, that's amazing. So we're gonna have a shit ton of data in one place. Who's gonna know what to do with it?
Yeah.
And that's where you don't hear people talking about.
Well, yeah, in addition to that, with value-based care arrangements, you have providers who are used to EHR data, even though that's maybe 10 years old now or maybe 15, but they're now getting claims data. Well, they've never had claims data before. So how do you make sense making of that? And then you add in patient-reported outcomes measures or health risk assessment or other kinds of data. I mean, this is groundbreaking. And so how do you develop algorithms to say, oh, this person's at high risk? You know what I mean? And the famous example I use is with health risk assessment. If you ask the question, what's your health status, and you rate it as poor or fair, and you have no claims data from the plan, that person's at very high risk for future health service utilization because they're assessing that there's something going on and they're not going to the doctor. You know what I mean? So it's really using data in very different kinds of ways and not just relying on claims data. Claims data is great, but there's all this other data, but sense making of it is going to take time, I think.
That's definitely a place for AI to start playing as well. And I think there is some activity in that space, but.
Interesting. Teresa, were you going to say something?
I was going to say on the personal, there's the personal data and then there's the aggregate data, sort of like how do you then take the information that you can aggregate on health plan, providers, hospital charges, and look at it aggregately and then say, okay, here's what I can do as a purchaser, here's what I can do as a consumer, here's what I can do as an employer, and say, how can we actually take this one thing that we know is true, opioids for dental care for teenagers, more than 1 or 2 pills. They don't need more than that. How do we sort of take that one thing and say, we can do something about that? And that's where groups like the Washington Health Alliance come into play around making that data in a neutral way, saying, here's the data, how do you want to play? And we convene, and as does Cambia Health, we convene groups to have those kinds of conversations to sort of empower and get out of your own sort of daily, sort of the tyranny of the day to actually look at those things and take time out and spend it.
And share that with patients so they
Yes.
know what the standard is.
It's
And-
public.
And,
Right.
but nobody really, nobody knows that. They
Okay, well,
give
we're
you
working
just a
on that.
whole bunch of pills at one time.
Well, and
Right.
that's, Bevan, did you have
And that's what we were
something?
talking. Well, I was just going to say that's what we're kind of talking about around empowering. So one of the things that employers can do is actually share that information with and help their employees be empowered to ask those questions.
Yes, ask the questions and also let them know that you can actually, if you get a prescription, you can go back and say, I actually just want one.
Or even before you get the prescription, have a
Yeah.
conversation with the dentist who's
Yes.
pulling the teeth of your wisdom teeth of your kid and say,
Yes.
we don't want it.
Yeah, yeah.
But you might need a policy change. When I worked on opioids in DC, you needed a policy change in order to be able to prescribe just one. You couldn't prescribe just one. You had to prescribe 10. I mean, this was 10 years ago, but that was an issue. It's probably changed since then, but it brings back into the policy realm of, yes, that makes sense, but you need policy.
Yeah, I was just going to kind of circle back around to kind of what I'm hearing too. One of the things that we hear all the time is it's fine to integrate these systems, right? We did a big overhaul of the behavioral health system, as Dr. Crittenden talked about, but one of the things that we hear over and over and over and over and over again is great, but we don't have any primary care physicians. Great, we don't have any behavioral health specialists, right? And so my question, and this might just be out to the entire room, is how do we do public-private partnership to incentivize folks to go to school and graduate with as a primary care physician, as a behavioral health physician? Because right now, the cost of that education is so cumbersome that my understanding is folks are like, no, I'm going into specialties. Like, there's no way I'm going to be able to pay back my student loans, and so here we are with a shortage. So that's my question.
I can't answer the cost part, but there's a guy named Ban Ku, Ku. I don't know if people know of him. He's He's at Jefferson University Medical Center in Philadelphia. So he actually goes to students at Princeton, I think, and he says to them he wants liberal arts people going into med school because he thinks they'll be much more well-rounded. So he goes to them and says, you know what, we'll waive MCATs. So he'll go to I think it was sophomores in college and say, I'll waive your MCATs if you enroll, but we want you to study what you're studying, not pre-med. And it's the reason why I bring it up is it's not answering the cost question, but it's a way of thinking completely differently about how do you incent the type of people you want to get into the industry who will pay off millions of times over later on.
Yeah, did you have something to say? Yeah, I'm coming over here. Someone else you had something, Bill? I'm going to after.
I'm not absolutely convinced that there is a physician shortage. I think that labor efficiencies have not been achieved through AHRs heretofore, but I think that technology and solutions of different ways of providing care, and frankly, that would be incentivized substantially by capitation, will achieve that. So if I can manage patients by the phone or by email or something like that, and again, at different levels of care, much of medicine is cookbook, 90%. And so you need the physicians who are at the very top levels. I think to incentivize, once the incentives were to change, should that happen, and Dartmouth's been predicting that incentive change and dramatic evolution to value-based care we're right on the cusp of it for the last 30 years. We've been on the cusp of this happening. But should that change, primary care physicians, the roles of primary care and mental health professionals will change kind of dramatically because they will be kind of have a much more substantial and important and influential role, I think, than the specialists who will be seen more as occasional use folks, I think.
And the same is true for behavioral health specialists. 50%, and nationally, 50% of behavioral health professionals are not a member of any network.
Michael, put your thing up.
And in the Bay Area, 75% of behavioral health professionals are not in any provider network. So the issue is not lack of behavioral health professionals. They're not joining networks. I think there are issues around why. I think payment is a big issue. And I have a colleague who actually was a consultant, got her master's in social work, became a clinical social worker, and she said she was making $20,000, $30,000 a year because of the overhead and the poor reimbursement. So she went back into consulting. So I think there's a reimbursement issue, and I think it reflects our culture's lack of value, in my opinion, of behavioral health, that what you pay people reflects what you think of their value. And so it's a badge of courage to say, oh, I don't take any insurance because I'm so good I don't rely on it. Behavioral health colleagues of mine that are in the profession. So I think we have to take a look at how they're paid. I think technology will also have it, so they can do virtual therapy.
Rochelle.
Well, I was just going to say, when you look at, I think current state, there is absolutely a shortage because we have decided people can do this at this level and this at this level. So we have absolutely created a shortage, even if you think empirically perhaps there wouldn't be. But that requires a huge redesign. And one of the things that we've been thinking a lot about is how far upstream can you go? And when you think about a nurse who becomes a nurse practitioner, and I'd love to hear from you we've talked a lot about this at Providence, is that when you get in the primary care sector and you look at chronic care management, a nurse practitioner tends to have amazing results. And when you look at the why, or you talk qualitatively certainly about the why, and if you look at some of the Vanderbilt studies, quantitatively the why is that they build a relationship with the patient who then cares, that someone cares about the outcomes to getting better. And so when you think about how do we use those nurse practitioners, instead of always saying it has to be an internal medicine doc who looks at our very chronically ill patient or those top ED admissions, but really but we have to train differently, we have to think about that differently, we have to pay differently. Upstream, there's so much redesign, or perhaps someone said don't blow it up, perhaps blow it up design and
I wonder if the insurers, if they did not pay for low quality care, that would free up a fair amount of workforce capacity. Huh?
I'll take that freebie. you probably don't want me deciding that. There actually is an abundance, it's been mentioned several times, of quality data on providers, but also a ton of noise. And getting to signal over noise, and then getting a community of providers and the overall ecosystem to accept actual tiering of quality is a major league endeavor. And there's other dependencies beyond just the provider and payer in that. And I'll put the purchasers on the front line for a moment, because purchasers are quite risk adverse, especially ones competing for talent and ones that desire broad networks and don't want to make the type of trade-off choices that wring costs out of the system, because it will turn potential new prospective employees away. So this is a true 5 points discussion.
Yes.
Consumers also have to be a part of that. Consumers want to trust and know that the payers are not overly engineering quality scoring to costs. They're going to want to understand that there's an actual concern for quality and outcomes, but yet making that visible and transparent can be, it's already been mentioned, totally overwhelming. People don't need 30 more choices on quality grounds. What they do need to have is confidence that between this ecosystem, we're really promoting the top performers, putting them at the top of provider directories, and really helping steer people to that best value proposition for them. It also opens up doors to personalization. Appreciating quality is in the eye of the beholder and in the eye of the patient. We often forget that. It's not just a metric. And so far, much of our systems have been really designed around arbitrary metrics and not the level of personalization that's appropriate. Okay, that's how I'll handle that freebie.
John.
So, you know, we've been part of the problem there, and the Centers for Medicare and Medicaid Services recognized a couple of years ago that there were too many quality measures for the Medicare, so they dialed them back, and I can't remember from how many to how fewer, but lesser. They said, this is imposing a burden beyond the benefit of getting these measures out there. And we also discovered that there are, like if you're in a community clinic, you're engaged with the Medicaid system, you're engaged with Health Resources Services Administration, HRSA, we say in short, and they got different quality indicators. So the Deputy Secretary, Eric Hargan, who you hosted here at Cambia Grove a few weeks ago, thank you for that, he actually convened that, said maybe we could get a set of common quality indicators for the same thing across different programs in our department. So we're working on that.
So is that a request from one of the points to the next? Common quality? Oh,
Yes.
Yeah.
Can I ask you guys a really candid question, because we're in a safe space? So, assuming that you could get the kind of personalization measures and the quality measures, you had a neutral party that was calculating, everybody agreed, it was perfect. You know, everybody, the consumers were in there, everybody was in there. Would you all agree to use that system, given today's competitive structure?
So it's kind of what's the common denominator that's non-compete? Don't compete on this one. It's common denominator.
I'm not sure what you're asking, because like if you talk about HEDIS, we're kind of all using the same, you know, there's real science to how that's measured.
Right, so I'm saying that would you all be willing to use the same measures across all these systems, not every plan measuring it, but just have a common thing? And then would it be somewhere you could all collaborate rather than say, oh, there's this thing there and then somebody else might want that, it's too risky, whatever. Would that be a foundational collaboration in the midst of all this noise that you could start with? I'm just curious, like where people are, because it's competitive and there's a lot of fear.
There's the issue, right?
Yeah, so that's my question.
So if you talk
in
about
the competitive environment that we're in right now.
Talk about Medicare, talk about stars, right? You know, stars rated from 0 to 5. The higher you get, the more money you get per member, and it's highly competitive. If, you know, I guess everyone could be a 5, right? But we're really measured against ourselves. So you're measured against the mean, and it's competitive. So my point is, you get what you paid for. So you know, if policy drives it differently, we would probably do it differently.
So we need 10 stars, because then 5 could be the baseline.
Well, if you make it dependent and competitive, if you say we're going to measure everybody and whoever rises to the top gets paid more, and you're constantly having that go up, you're really incenting competitiveness, and you're not going to get everyone doing the same thing.
Michelle, you've been patient.
Yeah, well, I think this goes back to when you talk, Bert, about everyone's talking about interoperability, but it's not just about the IT standards. It's about practice. I call it practice interoperability, but it's looking at the evidence that's out there, tying them to, evidence-based interventions, quality measures, and we do need to have some standardization around that, because that is what's going to decrease the variability in healthcare. And so I do think there's a call for us to have some standardization of care that's based on the evidence, that's tied to quality measures that we all can come to agreement on and to use. And we're starting to move that way. And the other thing, I'm on the stakeholder group for the National Academies of Practice, the ONC. And when we met with them, they didn't even know we existed. Here's 14 different professions. We represent medicine, nursing, social workers. And we really challenge them on, we need to look at the coding system underneath. It's been, and there, I know through the Cures Act, we have looked at E&M coding again. We're trying to get more simplicity related to that, but we need to move into, if we're really advocating for team-based care and coordinated care between nurses and social workers, that's the other thing that has to be looked at, is that whole piece of it.
I would just make a comment that we could come up with national quality standards, Dorothy, but I think also there should be standardization on health plan design, and that's the confounding variable. That's the confounding variable, right? So this gentleman has this cheap plan, but it's got low quality providers, sorry, and this gentleman has a, yeah, right, that's exactly right. And this gentleman has a more expensive plan, but the benefit plan design is richer, and you have all the whiz-bang, digital health apps and whatever. So that's the challenge, is looking, when you got to remember the journey from the member's perspective, for you have an employer-sponsored plan, is you have to choose a plan. And so just looking at provider quality doesn't tell the whole story. It's what's the plan design, and then I make trade-offs. And I agree with you that employers are risk averse. I think the climate right now is because talent's so difficult to get. They don't want to force someone into a narrow network or HMO or a gatekeeper model, because they're concerned that then people will not be attracted or stay with their employer. If that changes, when that changes, there might be some more openness for employers to do it, but it's a challenge. So plan comparison and then provider quality comparison in a standardized way.
And I was just going to push back really quick and say, as Dr. Crittenden said, I don't think we are getting what we're paying for in terms of quality. And I guess my question to some of the folks around the table is, how many people are looking at other developed countries that are basically on par where we are, and looking at the plans that they are offering to their citizens and comparing to say, hey, how could we do better in standardizing what we have here so that we are actually getting what we're paying for?
Well, and one of the questions for the patients was, and it could go to everybody, but this, I'm going to blush when I read this. Why do patients not demand better quality care? Why do you blush? Because that's an awkward question. Why don't you demand better quality care?
Do they know it? Can they define it?
Better quality care? I don't know.
No, but you can go to Consumer Reports and find out a quality car, but you can't really find out a quality patient or provider. And I think you guys said, someone said, oh, I go to my cousin or my uncle or something like that, or you stay within network, but you don't truly know the quality of care that's being provided. I mean, I actually think I'm not sanguine that the insurance company is going to solve stuff, because they have had all this data for quite some time, and I don't know. I think empowering consumers with actually maybe limited choices and benefit design, where you say, you have choice. You pick one of these 5, no copay. You pick these other ones, copay, because it costs you more to get poor quality care in the long run. And you get incentivized then to go to maybe a choice of a few, but ones that have been vetted to demonstrate that they continuously have high quality, low cost, high value care that they're providing.
Okay, so the first question is define quality.
And why not? And then why aren't we demanding it as patients?
But what is it, define it? What does quality mean? Does it mean faster outcomes? Does it mean amazing bedside manner? Does it mean holistic care? Does it mean reviewed, everybody gives them 5 stars? What does quality mean? I mean, that's my
And when you don't get it, you know, I go in for a LASIK eye procedure, and boom, I wake up and I can't see from here to there. That's a true story. And I said to my doctor, "Wow, this isn't really within the realm of the experience that I expected." I said, "What the heck?" And he said, "Oh, well, I've really never had this experience before." I was like, well, and so what do I do with that? I can't work. I can't, you know, immediately. I mean, it fixed itself over time. But
is that low quality?
so that's a good question. And right, and I could not do a darn thing about it. There wasn't anything to do about it that I know of, or somebody has some suggestion.
Yeah.
Well, I've spent 25 years collecting data from patients and families and trying to make a difference in organizations. And I think that part of it is the organization's willingness to hear it and to do something about it. So I have plenty of patients and families who have advocated so vehemently, and the organization doesn't want to do as much as they could. And then part of it is the systems that we've created internally. But then, so I love that all 5 of these points are together, but it does take a heavy lift and dedication and time. But I don't think that there aren't patients who aren't advocating that, because you said it this morning, every patient who has a bad experience does not want that to happen again.
Totally, I agree, and I think part of it's meeting your patients where they're at. Like if you know they work a work day, you know, 9 to 5, and you're calling them 9 to 5 for feedback, you're going to miss them, and that happens all the time. For me, I also think that fear and shame are what stop people from sharing feedback. You know, if my twin sister who went through sexual assault was told by the police it was her fault, she's not going to go, you know, to feel comfortable in the place of medical care, nor in, you know, the policy or public offices that make you feel safe. And so I think, you know, gender-based, race-based bias and violence in the world make it very scary to share feedback.
Like, just out of curiosity, who's seen that Seinfeld episode when Elaine goes to the doctor and the doctor writes something in the note? Yeah. Have you guys seen that?
Oh, yeah.
Right, and then she, like, right?
And she sees it in her chart, and she says, "I'm the problem patient."
Right. Anyway, and so just quickly back to your question about quality, right? So I guess the biggest point for me is who's defining quality. So I go to a naturopath, this is true, who I went in because 3 cardiologists had put me on Lipitor. I got in there within a month. He took me off Lipitor, put me on supplements, and brought my cholesterol way down. I would say that was really, really high quality care. Other people would say we don't cover naturopaths, right? So for me, my definition of quality is going to be way bigger than a corporate definition of quality might be, or a standardized definition of quality might be. I think that's part of the challenge with quality. It's a huge challenge, obviously.
Absolutely. Doug?
Yeah, just a couple of things. One, you know, we do measure quality. We look at the quality of a provider, the efficiency of a provider, and you know, in Medicaid, some of what we do is we assign people to primary care if they don't pick a primary care provider, and we will assign them to the highest quality, most efficient provider, and we have a lot of metrics around that. You know, so I think
What are they?
There are.
Sorry, I just have
if I
to
could
ask.
just finish,
Sorry.
it's really a question for the providers, though. I think one of the barriers is providers will really balk at having that information out there. I mean, we could publish that information, we could put that information out there, but I would ask the providers in the room, what would you think if you were measured? And someone said, hey, you know, instead of buying a car, you could go in here and you could find out who's the better doctor, who has the most quality, and who does it at the best cost.
Teresa?
So the Washington Health Alliance does do that. We do actually publish value and quality, and it's public and it's named, first in the nation to do that. One of the things, though, that I'm thinking about is that we're talking about quality up here and how we have to boil the ocean. What if we took the 47 low-value waste that everybody has agreed to are low value, meaning, and we looked at 9.5 million services for the commercially and Medicaid insured population between 2014 and 2017. 51% of those services were found to be low value, costing an estimated $703 million. These are things like opioids for conjunctivitis, or not, sorry, antibiotics for conjunctivitis, pink eye. You don't need that. You don't need opioids either for that. But they're really that really pretty much everyone agree. And choosing wisely is a nationally. And what if we started there? So you don't have to start up here. You can start with some of these really basic things that you can empower patients, purchasers, providers, and start to have those conversations.
So Washington Health Alliance has incredible data. Why aren't we using it? We didn't know it existed.
Actually,
Okay,
at
so now what
WASHA,
you
we
have
actually,
data.
well, we teach that in our public talks. So we do recommend that. We do a talk called Safe and Sound in the Hospital, and it's a short course in patient safety based on information coming out of Campaign Zero to prevent medical errors in the hospital. So we do include that.
I didn't really get my answer from the providers.
Okay, Doug, repeat. What was your question one more time?
My question was, how would you like it if information was published about your quality and your efficiency?
I'll just say that somebody did that. It was up at Regents upstairs here about 20 years ago, and he bounced out a few of the doctors. It was basically a revolution, and he lost his job. Yeah. That's why.
Well, so I think they should. You know, and I'm a provider. I don't practice now. Maybe that's why I'm so encouraged by the idea. But you know, it's you know that. But one of my favorite stories is Department of Health in New York has published risk-adjusted mortality outcomes from cabbage and PCI since 1988. It's on the web. You can find it. When President Clinton made his choice about where to go to get a cabbage, he went to the one bad outlier hospital in all of New York who had been a bad outlier for the last 10 years. And my belief is that Hillary chose it for him. But nonetheless, if our president doesn't use this information, they have it by hospital and provider, right? But the reality and the interesting thing is you can take two approaches. They took the approach of doing this, and what they found was a lot of the cardiac surgeons went to New Jersey. They just went across the river, and there you have it. They continue to practice. In northern New England, a group led by Dartmouth actually collected data, worked together in a quality improvement effort, and improved care quality and risk-adjusted outcomes over the same time period to the same level very effectively by collaboration and sharing of data. So I think that raises all boats. The other just pushes it off to some other state. I think that, though, publishing individual level data is kind of the way to go, and that would empower consumers to make better decisions. Frankly.
So I think quality needs to be completely redefined. We have historically relied upon claims data for quality. Claims data was never meant to measure or improve quality. We can make some extrapolations. And the growing movement for patient-reported outcome measures, where we look at functional improvement. And some people at public health say things like, for a pediatrician, high school graduation rate is actually the best measure of quality if you've had that patient or child or whatever in your practice. So I think if we completely reinvent, which is a heavy lift, I understand, claims are just easy to get, but claims are not, were never meant to do what we're trying to make it do. And so the other thing I would say is if you've ever gone to Nursing Home Compare or Home Health Compare, which is great that it's there, it is very difficult. I've tried to use it before, like, oh, well, this nursing home has more behavioral health. Well, they specialize in behavioral. I mean, so it's like, it's hard to say, oh, this is a good facility or that's a bad facility. And again, we're using claims data. It's imperfect. I think you alluded to it. And so it's really hard to make it actionable when you're looking for a place, you know, for a loved one or family member or whatever. Wait a minute, family members are loved ones. Sometimes. So I just think you know, we're going to look back in 10 years from now and shake our heads and say, can you believe we relied on claims data as the sole source of information for quality? I just think we have to really rethink what we think about quality.
Laurel, did you have something?
Oh, I was just going to piggyback off of what Teresa said about sort of the waste calculators being, it seems like a common denominator that maybe we could get around? I know as a payer, that's obviously something we would be looking to and are already looking to and trying to figure out what the process improvements are. But it would be helpful to know how to bridge that to the provider and the patient side to make sure that folks are accepting of the data as truly a waste-driven item to be pushed out of the system.
Phoebe.
I would question why providers wouldn't want to know the feedback and the quality ratings from the patient perspective. They are service providers. So theoretically, I get it. Like, we're not medical we're not medical professionals. We haven't gone through the training. But I certainly know when I am able to build a relationship with someone and when I feel like I'm being treated like an adult or treated like a child. And I've been in situations both ways. And I would want to be able to share that information, mostly, hopefully, to help improve that provider. So that if they're getting that kind of feedback, maybe they can improve. Because right now, I don't feel like anybody's holding providers accountable to who they are actually supposed to be working for, which is their patient. And right now I feel like as both a patient and someone who advocates for employees on the part of purchasers, I'm really uncomfortable with the fact that I am making business decisions, that are impacting the potential for a patient to get care or not get care. And I think that is something that we're not talking about, is that fundamentally we're talking about lots of money exchanging hands, but we're forgetting that the patients are at the core of this, and that's who we really should be focused on. So, off my soapbox now.
And quickly, I think that starts with discovery. And one of the things that early stage startups are really inspiring me in the space of health includes finding therapists. So another flag is that behavioral practitioner, or whatever the phrase is. I'm like, what does that mean? Because I only, my experience is with therapy. And so there's some really cool ones, at least 3 in Seattle, that are working on discovery. One, for helping practitioners become more discoverable, sort of on their own terms, and then saying, hey, you're coming from a low-income background, you probably appreciate talking with someone who can understand that kind of, omnipresent financial stress, any dimension of your identity, and I think that's a very important part of it. And then tying feedback into discoverability, like if you're high-rated, you're more discoverable, you get more clients. Again, it's in a very specific lens for therapy, but that is one that's inspiring me right now. And I hope it comes super soon, because it's just like me 5 months ago was searching for this on Psychology Today when I'm like, I feel like I can't find anyone.
Sorry, I'm sorry. Can I just ask one thing? I don't remember who said it in the corner, but you said that somebody at Regents once tried to tier and qualify providers, and then they lost their job. Are we being too nice? Does everyone have to be happy? Why? So I would say, I would just say for you, because you brought this up too, just publish it. Just publish the quality, and it's going to fall out the way it's going to fall out, and it's going to fall out the way a market's going to fall out, and you're going to have a huge population of people who are thrilled that you did it, because you're going to have much better information about where to go, and you'll have some areas that you'll have to work through. But it seems, the one thing I'd say a little bit just from today too is everybody, 5 points of health is not about everybody being super nice to each other and never offending the other point, right? The system is so messed up. Someone's going to have to break it. I would say, with that guy who got fired, he should be brought back, and we should build a statue to that guy. Right? But I'm serious, right? He took a risk, and he said, I'm now taking complete poetic license, but
Bert, who needs to move first? Who moves first? Because I can hear the conversation go, well, it's so-and-so's problem because so-and-so is doing this, and no, it needs to this over here. Who goes first?
I would say the payers.
Payers go first.
I think the payers have the power to start doing that. We're going to need more lawyers. Yeah. No doubt. But you know what? You'll have the entire population of human beings on your side.
Well, this is where public policy could be helpful, because what we really have is a series of monopolies and oligopolies. And we have whole sections of the state where we have low quality and the highest prices because we have a monopoly, and you poor guys are paying this fee, and you're paying for it too because your money goes up there. And I think in the well, I'll just say, I don't want to get too much into the doctor thing, but the doctors actually went on strike once didn't know about it. Nobody knew about it because it was the orthopedic surgeons, and they didn't like the fact that their rates weren't going to go up fast enough, and they were being kind of held back as they're trying to moderate. And they literally stopped taking any consults, and they did it in a what we consider a trust way, but they had formed an IPA so they could talk to each other, and because they shared risk, they could talk about these things. They basically stopped taking Boeing referrals, and that was the main thing. And Boeing went berserk and basically said, fix the problem, so they jacked their rates up, and they all got happy. They're now a very expensive and present surgical center group in town right now. But the point is that all these groups have monopoly power, and some groups really don't have any power at all, and I'll just say patients being one of them, that are outside the system in the sense of having the control. And so I think there's an economic power issue here that is real, and it does impede what we do.
So Bob, one of the questions is, why should patients trust payers? I think we should expand that to purchasers, providers, and policymakers as well. Talk about trust. So you just talked about business decision and everyone got rich and happy. What about trust?
Wait, so I'm sorry.
Yeah.
But how do we break it?
Yeah.
Right. So that's so yes, you're right. Right. It's all monopolies, and but somebody at some point has to have cojones. I won't use the English word for fear of offending anyone. But someone has to stand up and say, we're done. Like, we're not doing it. Here's what we're going to do from now on. We understand the risk involved, but the only way to drive significant change is to take a stand. Because, again,
Okay,
everyone
well,
is so nice.
Can I just say, well, she has to speak too, but I actually think that, you look at where the strategy is, and the power rests, I think, both with the purchasers more than anybody else, because they're the ones who can, if they worked in concert, could lay out what they thought were reasonable policies around different things, and they could drive it through the system very quickly. The only group there are only three or four groups in the state who are purchasers who are really doing a lot. Boeing is doing a lot, and I think, but they feel powerless because they're only, 30, 40, 50,000 employees. The state actually, through HCA, wherever, has done more than probably anybody else as far as changing the way we purchase and really putting quality up and trying to measure it. And King County's done a lot over the past. And those are, after that, it gets real thin.
And Microsoft as well.
Have you done? Yeah, you're doing working with them, aren't you?
One thing that's just really occurring to me, I'm a big advocate of council infrastructures so that people can learn together over time. Have any of you ever been on a committee or task force and they come together and do the Band-Aid solution and they go away and then you have to come back and do it again? And I love the 5P model because it's bringing all the different pillars, and we do have to collaborate, we do have to know each other. But I'm sitting here wondering, as we're now sitting around the table together, what if we were all together over time for a while where we could really learn from each other, with each other, about each other, and the impact that would have for us to understand the both and that we're all talking about. And so we could really understand competition and collaboration, and we could really understand, the patient's needs and the provider's needs, and and all the way around. But that, to me, would be really exciting if we could figure out a way to do that. And I think that would get away from the quick fixes and the Band-Aid mentalities.
So, Michelle and everybody, I swear to God, I didn't come here to just plug Alliance for Healthy Washington. But to answer your question, that is one of the reasons that we formed this, was to raise the issue outside of the status quo, right? I mean, the reality is that there's no way that patients or consumers in general, or individual unions, or small businesses are going to outraise or outfund the status quo, right? But as Dr. Crittenden mentioned earlier, and as I think we talked about on the policy panel, if we do come together jointly and cohesively, we can push the envelope on that. And that was the point of developing this organization. And to your point, Michelle, one of the things that we are doing is putting programs together for our member organizations that explicitly have to do with that, educating each other and coming to the same table and having those conversations.
Negan's been trying to talk for a
Maybe you won't want me to. I wanted to accept the challenge. It was offered a moment ago of payers acting first, but give credit where credit's due. It was just referenced. The state did some pretty major work in lifting for purchasers over the last several years. One example of that is implementing a pretty progressive total joint replacement program that, to explain it briefly to this audience, is a single price with quality guarantees for all hip and knee replacements. And that program's been in place now for several years. The notion when it was launched was that the state would move first and others would follow. And I was so pleased, having made the progression to where I am now, that Premera followed in those footsteps and actually just in this month launched its own total joint replacement program. Very similar design, different provider partner. That provider partner's at this table today. But that provider partner committed to some guarantees that I think are less confusing for the consumer. A price that exposes them to less costs and a lower premium, and guarantees around quality and the experience they will have that they'll now have to live up to contractually and we'll be monitoring. But rather than making a member go to a website or go to a place where they have to compare 20 different hospitals that can offer this service, we decided to take the approach the state did before us of productizing it and saying, if we can get the best price, we can get guarantees around quality, we'll serve it up. In Premera's case, similar to the state, most members who access this product will do so without any cost sharing. And that's because Providence was willing to deal with Premera in a very different, creative, and I think trust-based way. The other example doesn't involve Providence, so I'll reference it with Microsoft being, I think, one of the more progressive health purchasers in the state. Launched a accountable care network with 2 Eastside hospital systems, where there were guarantees offered around really the patient experience and quality outcomes, even ordered above certain cost elements. And that program is being jointly administered by 3 of the Ps. You have a payer, you have a purchaser, and a provider that are all leaning in, and we're learning a ton. One of the things, though, that's interesting in that program is because people now have this product around them, we're serving up to those members that have selected that product very detailed quality information that within that narrower network will now allow them to make better choices. I'll be honest, I'm a little dim on the prospects of 90% of consumers tomorrow going to shop on that basis. And here's the number one reason. We started the day this way. We're all patients first. Think of our own behavior. I cannot think of a time, and I'm not proud of this, where I chose to ignore a primary care physician referring me somewhere or a family member somewhere, and as opposed to that went to the Consumer Reports or to that version of healthcare quality. Maybe we'll get there someday, but I think it is on the payer community and the purchaser community secondarily to be more active in their purchasing behavior and to put forward products that do some of the heavy lift, that do rely on the fine work of the Alliance and others to tell us who the quality providers are, but then to make it really easy for consumers to take advantage of that. I just wanted to offer those thoughts.
Totally agree. And when I switched jobs, one of the most, and like luckily there was 2 options for me, but even within that I was like, wow, 60-page PDF. Like, how do I understand? And what's the difference between like Novolog and Humalog? Which do you cover? You don't know? I call Aetna. You don't know? And it's the back and forth again. And I think one differentiator for employees that offer healthcare or employers that offer healthcare, it would be like you can Yelp your healthcare and get like the $, the stars, and everything. And I think, well, like, healthcare in my mind is this, glowing object of innovation and goodness. And I think sometimes like taking that down a notch and not elevating it so high and saying like, sure, it can be as easy as e-commerce and, review sites and all of these things, because that's what your public is experiencing on a daily basis, would be very, very cool. But even like just the feedback that helping you make that decision is so, so critical, especially when it's so confusing. And all these acronyms, Microsoft already has enough acronyms. I'm like, SOS, another acronym. I think the long story short is that, you're hungry to learn as long as it's easy. And so making it easy, then I think there will be a ton of interest. And my one more question would be like, we haven't talked about part-time employees or unemployed people, and I think that's really important to consider is like, these are such luxuries, and how do we think about access to this kind of information?
Absolutely. You all, it
More,
is-
could I just make one point? So I want to just make the point that with centers of excellence, which you're referring to, the cost savings that both Walmart and the Healthcare Authority have realized is for people who avoided surgical procedures. So I want to just, someone was talking about efficiency measures. We don't want efficient services for the wrong thing. So be careful how you design those. And there's some COE vendors out there that go, oh, we got a cheap price. And it's like, well, cheap price for something that's not necessary. The other thing I will say, I want to go back to quality measures, is I remember back in the day, when I was doing case management, I would have an injured worker, and they had back surgery, and I'd meet with the orthopedic surgeon, and he would say, it was a great surgical procedure, but the person wasn't back to work. It was not a successful surgery. The functional improvement was not there. So, the technical surgical intervention apparently was good. I'm not a physician, so I didn't know, but all I knew is I had an injured worker who couldn't get back to work because the recovery wasn't there and the surgery, anyway. So, be careful what you measure and how you measure. And again, another plug for functional improvement.
Such good conversation. Please join me in thanking the Fishbowl panelists.